Currently, I think the data suggests that the best initial induction therapy for patients who are transplant ineligible, in my opinion, is daratumumab-lenalidomide and dexamethasone, DRD. So the MAIA trial has shown excellent response rates, greater than 90%, deep responses and durable responses. At an updated ASH of this past year, it looks like the duration or the PFS is going to be in the order of 50 to 55 months. Now that's a year or more longer than any other PFS in any other triplet-based induction therapy in the transplant-ineligible patients. We have RVD Light, which is right around 30 to 36 months. We have the SWOG study that was right around 40 to 43 months. And this one, again, is 10 to 12 months longer. So I think its side effect profile is very appropriate for the transplant ineligible, very well tolerated regimen. And I think we're going to see more patients getting that as frontline therapy. Now, that said, as we move into some of the novel therapeutics, I think a combination of therapies, including the bispecific T-cell engagers, potentially as consolidation therapy. Maybe patients get DRD for 6 cycles and then transition to a bispecific T-cell engager if they don't achieve MRD negativity or at least a CR in that time frame. I do think that incorporating some of the novel therapeutics that we're seeing tremendous responses in the late line therapy into the therapy for transplant ineligible patients is going to be a winning solution in the future. I also have said that I do think that CAR T cells are better tolerated than autologous transplant. And so when we talk about transplant ineligible patients, those patients don't translate into CAR ineligible patients. There are many transplant ineligible patients that potentially could be CAR eligible. So the other possibility is to give them a triplet like DRD for 4 to 6 cycles and then take them to a CAR T cell therapy and have it as a one and done. And then they're done. And we'll see if we can achieve a PFS of 50 months or 60 months with just 4 to 6 cycles of DRD and a CAR T cell therapeutic. I actually think that's going to be a strategy where patients then undergo therapy for less than a year and may have remission durations of 4 or 5 years. That's a winning combination in my mind.